Chronic prostatitis and chronic pelvic pain syndrome can be a very daunting condition, one in which affects millions of men. Affected individuals having pain which can be debilitating, affecting one's ability to perform a number of ordinary tasks, such as sitting or walking, which can really upend an individual's life. I'm very excited to be collaborating with Dr. Daniel Kirages from the University of Southern California, who has helped organize a 3-episode Chronic Prostatitis, Chronic Pelvic Pain Syndrome series, starting with an episode on the research or science side, then the urologist perspective, and we'll wrap up with an episode on the physical therapy intervention side. Today, we'll be able to sit down with one of the world's scientific leaders in chronic prostatitis and chronic pelvic pain syndrome, Dr. Jason Kutch from the University of Southern California. So listen in. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. I'm excited to be sitting here and chatting with Dr. Jason Kutch. He is an assistant professor in the Division of Biokinesiology and Physical Therapy at the University of Southern California. He received a degree in mechanical engineering from Princeton University in 2001 and his PhD in applied mathematics in 2008 from the University of Michigan. Dr. Kutch is the director of the Applied Mathematical Physiology Laboratory at USC, and his work focuses on revealing brain mechanisms of muscle control, engineering non-invasive systems to study human motor function, and understanding chronic pain disorders. He is an investigator in the NIH-funded multidisciplinary approach to the study of chronic pelvic pain, or MAP, research network, with a particular focus on understanding brain network mechanisms of altered pelvic floor muscle control in individuals with chronic pelvic pain. His work includes publishing the world's first neuroimaging study comparing men with chronic pelvic pain syndrome to healthy men. He teaches neuroscience in the USC Doctor of Physical Therapy program. He has also been involved with the International Pelvic Pain Society and currently serves as the Scientific Abstract Review Chair. Dr. Kutch, welcome to the Prostate Health Podcast.
Great. Thanks for inviting me, and it's great to be here.
Yeah. So how did you ultimately get started down the path of what ultimately led to being one of the premier investigators for chronic prostatitis and chronic pelvic pain syndrome?
Well, it's an interesting story and a bit of a fortunate accident. In kind of 2006, 2007, I was working on my PhD in applied mathematics at the University of Michigan. Because of the way my program was structured, I had the opportunity to spend some time collecting data for my dissertation at the Rehabilitation Institute of Chicago, which is in downtown Chicago. And at the time, I was staying in Evanston, Illinois, which is about 12 miles north. And I got into commuting by bike. And after about a year of that, and when I was just about finished up in Chicago, I started getting pelvic pain symptoms and really struck me very hard. You know, bike commuting had become a very important part of my daily routine and my life. And these symptoms came up and didn't go away when I stopped biking. And so I moved back to Ann Arbor to finish writing my dissertation. But like I said, the symptoms in some way kept getting worse and worse, even though I wasn't biking anymore. So pretty miserable time, but I was able to finish my PhD and then moved out to Los Angeles for a postdoctoral fellowship. But again, I was just really unhappy because of this persistent and inexplicable pain. And so I came across some literature, you know, as I was doing my postdoctoral work in biomedical engineering, and it wasn't particularly pelvic pain focused. It was just, I was continuing my line of research, looking at how using mathematical models and other tools to understand how the brain controls muscle and controls movement. That was like the big area of my research. And I started to come across more and more literature suggesting that chronic prostatitis might have something to do with pelvic floor muscles. And also, since a lot of the people in my field were applying their work to problems like stroke and spinal cord injury, there was really a gap where no one was applying the kind of tools that I was working with to the area of chronic pain. And so when I interviewed for my faculty position in physical therapy at USC, I really took a chance and talked about the importance of chronic pelvic pain and how my research could apply to that. And I had the fortunate accident that they just had hired Dr. Dan Kirages, who you had on our previous podcast, to build up their clinical practice in pelvic floor physical therapy for both prostate cancer and chronic prostatitis, chronic pelvic pain syndrome. So I really owe a lot to our chairperson, Dr. James Gordon, for kind of early on recognizing the growing field of pelvic floor physical therapy and seeing potential collaboration between a clinician and a researcher. And a kind of final piece of the fortunate accident puzzle was that when I started my faculty position, the NIH had relatively recently started the MAP Research Network. And there was more and more emphasis being put on this problem of understanding chronic pelvic pain. And the principal investigators at the UCLA site. So I'm at USC, the big rivalry between UCLA and the USC for sports, but they actually get along quite nicely for research. And so Emerin Mayer and Larissa Rodriguez were the principal investigators at the UCLA site. And I came to them with some ideas about how to look in the brain to understand what was going on in chronic prostatitis, and they were excited about it, and I started collaborating with them. Dr. Rodriguez has since moved to the Department of Urology at USC, and we're close collaborators now on a number of different projects. So that fact that they had just funded that network and were building up the brain imaging portion of that really enabled me to ask some questions very rapidly about this condition that may have been very difficult otherwise. So a lot of, perfect storm, so to speak, of some fortunate accidents brought me to this field.
Oh, we really appreciate you sharing your story and how you got to where you are today. And from what you have found in your studies and learning more about chronic prostatitis, chronic pelvic pain syndrome, has there been an established cause yet for the condition?
Well, unfortunately, it's still a syndrome, united and unified by a common group of symptoms rather than a disease, which would be, defined by a specific mechanism. But that's not to say that there are not commonalities that we see among men with the syndrome that point to, if not one, of maybe a relatively small number of different disease mechanisms. So, I want to first say that when I'm talking about the what we've learned in research today, I want to basically say that we're going to start by assuming a man with persistent pelvic pain has been, thoroughly examined by a urologist, that they have no known pathology or cancer present. And so we want to take that as a starting point to, obviously if something like that was going on, the understanding would be very different. But assuming that, you can ask, first of all, is long-term chronic pelvic pain caused by a sustained but hard to detect infection of the prostate? I think that's when most guys come into this situation and they start doing some reading. The first and most natural thing for them to think about is it an infection of the prostate? And the research on this has been pretty substantial, and it says possibly, but most likely not. And the most definitive study from this came from Dr. Curtis Nickel, who's at Queen's University and part of the MAP network, who a couple of years ago used some next generation sequencing to look at bacterial differences between men with and without chronic prostatitis. They looked at a number of different specimens. So looking at VB2 specimens, which come from the bladder, VB3 specimens, which come from the prostate, and VB1 specimens, which come from the urethra. And there were no differences between patients with CPPS and those without in either the VB2, the bladder, or the VB3, the prostate. There were a few differences in VB1 that they noted between patients and controls, but there were actually some bacteria that were more abundant in patients and some that were more abundant in controls. So even though there were some differences, even as Dr. Nickel will point out, the clinical significance of quote unquote minor microbiome differences in VB1 really remain unclear. So I think that the answer to, is it an ongoing infection, is likely no. And I think it's become increasingly clear from studies that I've done, as well as many others have done, that something related to how pelvic floor muscles are controlled, how their activity is regulated, and how sensitive a person is to the kind of sensory motor activity in their pelvic floor region is involved in chronic prostatitis, chronic pelvic pain syndrome, but it's still a very active area of research. And we still think that there's probably subgroups or even, further subdivisions of the patients based on, specific disease mechanisms.
Well, when looking at current treatment studies, what have you learned about the ways of treating the condition?
That's a fantastic question, because we do work in research to kind of learn more about the population of patients with the condition. When the NIH originally funded the MAP Research Network, it represented kind of a shift away from funding treatment trials. There had been a couple decades of treatment trials, both in interstitial cystitis as well as chronic prostatitis, that had kind of yielded mixed results. And there wasn't any clear therapeutic agent that was emerging. And so the NIH said, look, we have to take a step back and look at the biology, try to understand this population better, and sort of pivoted away from, randomized trials. That's interesting from a research perspective, but, I can understand this as a patient that that's going to be frustrating as well, because it's not going to push forward new therapies as quickly as would otherwise. So this is always this balance between trying to understand probably a heterogeneous population like this, so you can design more targeted therapies, and sort of balancing that with getting towards new therapies. So looking at the treatment studies, Dr. Nickel has put out a very nice review of different treatment approaches that are out there and how they could be applied to the current subpopulations and subgroups of patients that are expected to be there. I would say that generally speaking, there's no good evidence for the long-term use of antibiotics, at least in what I would call a quote unquote open loop way, where you're just giving months of antibiotics without looking for specific culture evidence of elimination of a particular antigen and just saying, let's try multiple months of antibiotics. I think that approach, I was treated with that initially. I'm sure a lot of other men have been treated that way too. And I think that approach is particularly problematic as a long-term treatment strategy, because since it's a symptom that's based on, or it's a condition that's based on a symptom, and there's really no objective marker that you could show a patient and say, look, we're reducing this level of a particular pathogen, or we're doing this other thing that's going to improve. It's particularly problematic to apply a treatment for a long period of time and have the patient not see results. That can be kind of further the kind of psychological phenomenon of helplessness or learned helplessness, which I think has a way of potentially doing its own form of harm. So that's one thing I think that the treatment studies suggest, that it's not a good idea to do long-term antibiotic therapy. There's also been no quote unquote generally effective strategies identified. And what that means is that there's been nothing that's been identified where you could take anybody who expresses the cluster of symptoms associated with CPPS and expect it to work better than a placebo. And there have been a number of well-designed placebo-controlled studies for CPPS. And as I mentioned, Dr. Nickel reviews these in a nice article in 2019 in the World Journal of Urology. But, there's quite a number of problems with those. The largest of the studies have failed to show benefit, including alpha blockers and pregabalin. A number of smaller studies do indicate benefit from some different therapies, but it's unclear how those are going to generalize. And that's probably due to the heterogeneity of the chronic prostatitis population. So when you do a small study, a non-multi-site study, what's typically happening is you're recruiting a particular group of patients. And this can often be done, without bias or without any intent. It's just that a particular provider or a particular researcher may tend to see a particular patient type. And then they recruit that group and then show, early evidence of a particular therapy, but it doesn't tend to then pan out in a larger study, even with the same group of symptoms. And that's just generally a well-known problem with small studies. So that being said, I think that Dr. Nickel does a nice job in his review of talking about the U-points classification system that's been developed to try as best as possible to break the population down into smaller groups, those that may have more of a urologic or bladder-centric problem, those that have more of a pelvic floor-related problem, those that have tenderness versus those that don't. And there's some, at least clinical algorithms for applying particular treatments to particular subgroups. And I think that that's the right approach, although there's not been a large multi-site clinical trial done yet using that kind of more detailed phenotyping approach. But hopefully that's really going to be the push in the next couple of years. Now that the MAP is wrapping up its second phase study, the next set of studies will be, I think, very subgroup targeted therapeutic studies.
Well, thank you for that excellent review. And so you've been involved in the MAP network, again, as you had mentioned, the multidisciplinary approach to the study of chronic pelvic pain. Could you tell our listeners just a bit more about what this network is?
Yeah, so this was a really exciting effort to bring together a lot of great researchers from across North America to work on pelvic pain. It started back in 2008, 2009. They ran initially a patient control study that ran up to about 2013. And it was really one of the first large-scale multi-site, quote-unquote, phenotyping studies that was done, where the purpose was to gather a large amount of questionnaire, biologic, neurologic, neuroimaging data, quantitative sensory testing to determine sensitivity, to really kind of create as complete a picture as possible about patients with not only chronic prostatitis, but also interstitial cystitis. But it was a really big push of the network to study both men and women, to bring them under this umbrella that they used of urologic chronic pelvic pain syndrome, or UCPPS, which is another acronym that's been used in this context, because there are a lot of similarities between those two conditions. So it's a very large network. There's been many, many studies published from it. I had the privilege of directing the neuroimaging working group of that network. It's obviously focused on understanding the neuroimaging data. And we summarized our findings in a 2019 paper in Nature Reviews Urology. And it was really interesting what we found. We found lots of changes in brain structure and function in patients with chronic pelvic pain in a number of areas in the brain associated with pain perception and pain mitigation. But I think most surprisingly, we found extensive changes in areas related to the sensory and motor function of the pelvic floor muscles. And that was one of the things that I kind of brought to the network. Not that they didn't understand previously the importance of the pelvic floor in these conditions, but I had done a lot of work in my own lab, really doing detailed studies of where exactly in the brain are pelvic floor muscles sensed, how are they activated by the brain, how does the brain coordinate them under a variety of different systems and scenarios. And so I kind of came to the MAP network equipped with that knowledge and said, I think these would be really great areas to see how does a patient's brain function in those areas compared to a person without a history of pain. We identified a large number of changes in those sensory and motor areas related to the pelvic floor muscles. We also had some success in identifying areas of the brain whose function predicted whether symptoms were going to tend to improve over time or not, which I think was really important. And it showed that attentional mechanisms probably play a big role in symptoms as well as these sensory and motor areas of the brain. And then finally, and probably most importantly for the network, we identified that there were particular areas that were really overactive in patients with widespread body pain. And I think this is probably one of the most important contributions of the MAP so far, is that recognizing that all the pelvic pain patients are not the same. And one of the most important ways they differ is whether or not they have a history of widespread pain across their body. Those that do not are probably more likely to have peripheral disease and those that are more likely to have those that do have widespread body pain are probably more likely to have a centralized disease, meaning that the problem in the neural circuitry that processes nociceptive or potentially threatening stimuli and converts them into pain perception, which is much more linked with the body's response to pain. And I think when people hear this at first, they might be a little bit unnerved by that, to think it can very easily become a scenario where a patient thinks like, oh, I'm being told that this is in my head. And it's interesting because I myself am very much more in that centralized pain category. So pelvic pain for me came as part of a progression that started a few years earlier with unexplained chronic migraine headaches. And then a couple of years after that, unexplained chronic low back pain. And then pelvic pain is just sort of built on top of that, which is a very common progression in these patients with widespread pain. Pelvic pain isn't necessarily the first thing that they experience. Is often something that's happening in a much longer term progression. And MAP has found that patients with widespread pain, in addition to the changes in brain function that I described, have more profound inflammatory response in their cells when their cells are stimulated. And they also tend not to improve as much over time, really suggesting that they need targeted treatments that are different than those that have a more sort of peripherally focused disease. And this has been the largest distinguishing category that MAP has identified in a very large number of patients through years of study. And so I think that's probably the most important contribution of the MAP research network, is identifying the widespread centralized phenotype, recognizing that as an important subcomponent of pelvic pain patients.
Well, thanks for that excellent summary of the MAP network. And seems like it's been a very kind of valuable, network to have in place and to continue to further the research that we have so far. And now next I was going to see if you could tell our listeners about your current NIH-funded study for chronic pelvic pain syndrome.
Yeah. So a few years ago, I was able to get a study funded for linking those changes that I had found at the level of the brain in these areas that controlled the pelvic floor with actual pelvic floor function. So that wasn't something that the MAP network had this brain imaging data available, but we're not really looking specifically at the pelvic floor. And one of the nice things about the MAP network was that you could kind of use it as a central repository of a lot of data about a lot of people, and then kind of build little studies or smaller scale studies that could link with it. So what I did was I had a study where we've just about finished wrapping up that study. It has 42 men with chronic prostatitis and about the same number of male controls without CPPS. So it's a medium-sized study, but it's the first of its kind because it examined the pelvic floor function and brain function together at the same time. That had really never been done before. And so we use pelvic floor EMG to study how pelvic muscles are activated under a variety of conditions. We use MRI as well as electroencephalography or EEG recordings to study how the brain is activated, and some ECG or electrocardiographic measures to look at autonomic nervous system activity. But nicely, we can use exactly the same questionnaires that MAP does, identical MRI techniques, and so we can really kind of build up a more complete picture of patients. We've just finished. I won't say too much about it because I want to emphasize the results haven't been peer reviewed yet. So these are studies that will be hopefully coming out soon, but I'll give a little snapshot. The first study that we just finished writing up, I think, is a pretty exciting groundwork. It does show indeed that men with chronic prostatitis have difficulty controlling their pelvic floor muscles. The pelvic floor muscles in men with chronic prostatitis don't relax as they should. So what we do is kind of look at pelvic floor muscle activity at baseline, and then we have participants do a series of pelvic floor contractions, and then we can look at how their pelvic floor relaxes after the contraction is finished. And so if you measure pelvic floor muscle activity before and after a contraction in an individual without CPPS, there's no difference. Their pelvic floor is at a particular level of activity. It contracts, the pelvic floor squeezes, and then it relaxes. And then the amount of activity in background will be the same before and after in a person without pelvic pain. In a person with pelvic pain, the resting activity after the contraction is higher than before. And interestingly, this was most prominent in the approximately 70% of our patient population that endorsed post-ejaculatory pain. So those that endorse post-ejaculatory pain, which is the majority of the patients, have the strongest difference in the pelvic floor being unable to relax. And I think it's interesting because, ejaculation is related to repeated strong contractions of pelvic floor muscles. And so it sort of makes sense that inability to relax may be most prominent in those patients. We're now in the process of seeing how this inability to relax relates to the changes in brain function. So that'll be the next thing that we analyze. It's not too hard to see how this could potentially cause a long-lasting pain problem if the person is not able to regulate activity in pelvic floor muscles and the pelvic floor stays contracted. Just like any muscle in your body, if it were to stay contracted, it's going to eventually either do one of two things: be painful in and of itself because it's remaining in this contracted state, or two, it may be painful because it is sensitizing nearby tissues. It's, kind of creating more ongoing activity in the sensory nerves and sensory nerve endings in that area, and kind of creating an ongoing hypersensitization of the underlying tissue. So there's a variety of mechanisms by which uncontrolled excessive pelvic floor muscle activity could create those pelvic pain symptoms. So that's where we currently are with that study, and I think there will be a lot more exciting work to come from that.
Well, certainly look forward to seeing the results when that comes out and gets published. So now for someone wanting to get involved in some of these studies, how does one go about doing that, not only from a patient perspective, but maybe even a provider perspective as well, in looking at getting some patients into these studies?
Yeah, so that's a fantastic question. From a patient perspective, we're not recruiting at the moment, but I expect that we will be starting follow-up studies fairly soon on chronic prostatitis, especially preliminary treatment trials of non-invasive brain stimulation. I have a new treatment trial funded by the NIH in my lab to do transcranial magnetic stimulation in women with interstitial cystitis, which MAP has shown has many similarities with chronic prostatitis. So I expect that we'll be starting these kind of preliminary follow-up studies soon, and I would encourage any of the listeners that might be in the Los Angeles area or be traveling to the Los Angeles area and are interested in learning more to contact me about participating in a study. For providers, I think it's very important to get involved in research, both to contribute and to benefit from the research efforts. And how that's done, I think that researchers are always looking to collaborate with clinicians in this area, because clinician may have two things. One, a keen insight into a pattern that they've observed in their patients. And second, that they may have been able to collect a small amount of pilot data in their clinic documenting that pattern. And it's usually these data that are valuable to the researcher, because they can start to then use that to develop a picture and develop a formalized research question that they can then apply for funding to do a larger study together with the clinician. One of the most interesting things about the MAP research network is that now that they've collected this large amount of data, it's not as though the network itself is going to have the time to completely interrogate all of the interesting questions that can be asked about the data. And it was set up from very early on that part of the reasons for running the MAP research network would be to create this national resource for people studying pelvic pain to be able to access that data, which will very shortly become publicly available, and be able to ask questions about it in conjunction with a researcher. It's just this enormous wealth of data where then you don't have to go out and collect data from another 600-800 patients when it's already there and available to work with. I think it's very important for providers, clinicians to become active researchers. I just think about it from my perspective. I'm an active researcher and an active teacher in the physical therapy program, and I couldn't decouple the two. I think being an active researcher makes me a better teacher. I expect that it would be very similar between being an active researcher and an active clinician to best engage with patients, even if you didn't have necessarily the most immediate clear answer from the research to provide the patients. it would help engage with the patients to be able to think about all of the research that's out there and how it might potentially apply to their particular case.
Well, you mentioned your own personal struggles with chronic pelvic pain syndrome and kind of touched on some of the, maybe quality of life factors that kind of went into that and how it affected you. But maybe if you would mind sharing with our listeners, how did it impact your life?
It was very interesting. It didn't prevent me from doing any of the activities that I would otherwise do, but it really impacted my ability to enjoy those activities to the same degree, because really everything became potentially tied up with the pain experience, both physical activity, sexual activity, really just, especially early on, even activities of daily living, like sitting in a chair, become excruciatingly painful. It's very difficult to process because, I remember early on going to meetings or even sitting on an airplane and just being in excruciating pain and thinking like, is it possible that everybody on this plane or in this meeting is experiencing the same thing that I am? Like, it couldn't possibly be. They would all be going out of their minds. Like, it's just... And then it feels very puts you in a position where you feel very alone because you think, well, maybe I am the only one on this plane experiencing this, or maybe I am the only one in this room experiencing that. And so I think more so than a particular activity that it limited me from doing or said that I couldn't do, it just had this kind of undercurrent of making everything kind of unpleasant. And so I think, fortunately what happened is that it becomes less potent over time. And if we could understand that better as researchers, we could help accelerate that. And that's one of the main things that, we're looking into from a research perspective is how can we get people better faster? We know people tend to improve, generally speaking, over time, but it's excruciatingly slow. How can we speed that up for individuals? I think that one of the most important things for me that I'd like to share with your listeners was in general in the physical therapy world and in sort of movement performance world, we often think about things in terms of internal versus external focus of attention. So if you're learning how to kick a soccer ball and you're thinking about exactly how your leg is going to move, that would be considered an internal focus of attention. If you're thinking only about the soccer ball and how it's going to move after it's kicked towards the goal, that becomes an external focus of attention. And what became very helpful for me in the last few years, and which I think finally got my symptoms to basically completely go away, was to really find activities for me that promoted a strong external focus of attention and diminished an internal focus of attention. So I will share the example of two activities for me, one which is very helpful and one of which is not so helpful, even though they both involve physical activity. So one that would be not so helpful would be running. So if I'm running, I'm just constantly thinking about how much my body hurts, how much my legs hurt, how much my, everything hurts. It's very uncomfortable. And all I can do is focus inwardly on all of those things that are going on inside my body. The activity that's been very helpful for me with respect to pelvic pain and in general more of my other chronic pain symptoms has been surfing. So for me, surfing is a situation where because everything is going on outside of you, the wave, the being in the water, you don't really have time to think about how your body feels. It really pulls your concentration into that external space. And for me, in my research, this has made a lot of sense because a lot of the brain imaging differences that we see between patients and controls are in these circuits in the brain that are associated with more inwardly focused attention, areas of the brain that are more associated with interoception, monitoring internal bodily, function and processes. And so it's been very helpful for me to find activities that sort of down-regulate that internal focus and up-regulate my external focus. And so that really has diminished and very much improved my quality of life and how these symptoms no longer play the same role in my experience that they did even 5 or 6 years ago.
We really appreciate you not only sharing your kind of research expertise, but also your personal experience as well. And so in conclusion, Dr. Kutch, any final thoughts for our listeners today?
I think it's only just to reiterate that, many people have been through this. I hope that nobody feels alone with their symptoms. I hope that everyone understands that the symptoms will likely improve for them, but that it can take a frustratingly long time. And that's why researchers like myself are working hard on this problem to help speed up that recovery, because we don't want anybody to have to suffer with these symptoms for as long as they last.
Well, thank you so much for joining us today on the Prostate Health Podcast. Just an outstanding way to kick off our Chronic Prostatitis, Chronic Pelvic Pain series. And you really delivered up some very valuable and impactful information today that will really serve as the foundation for this series. And thank you for taking time out of your busy schedule to speak with our listeners today on the Prostate Health Podcast. Thanks again.
Oh, it's a real pleasure. Thank you so much.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/prostate health podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.